And about half of what I'm going to tell you will ultimately be proven wrong, and it's your job to figure out which it is. But it's because we've improved the diagnosis and therapy of glaucoma. Before we start, you should know I'm a consultant for Zeiss Meditech, where Mike probably also has some. And is your mic on?
Is my mic on? It is now.
I want to put it on, otherwise they'll way in the back. They won't hear you. Sensimed is a company that makes a contact lens that tries to measure eye pressure. Graybug is a Hopkins company developing what I'll talk about very briefly at the end, which is sustained delivery drugs that replace eye drops. AC Immune is trying to produce neuroprotection, and I consult with them on human trials. Now, what we're going to do is look at a lot of subjects relatively quickly. Mike is going to interrupt me, hopefully, at any point where he thinks I've really gone crazy or where he disagrees. You're welcome to ask anything you want. Just stick a hand up, and if I can see you through the spots, I'm happy to just stop and have you ask then. If we wait until the end of the hour and 20 minutes, nobody will remember what question they had, and that's kind of a bad thing to do.
My job is to ask Harry the questions you're already thinking of.
Good. Excellent. Now, the first thing I want to say is that glaucoma is not a disease of elevated eye pressure. Everybody who thinks about glaucoma says it's a disease of high eye pressure, and that's wrong. And it's been proven so many times now that it's almost silly that when you do a population survey, you find that those who have glaucoma, whose curve is here in the red graph, have a very similar intraocular pressure distribution to the normal population, though it is a higher average pressure. And guys, you may want to turn the sensitivity down or turn the vol down on this, unless it's my cell phone, which I can turn off. Maybe I just better turn the cell phone entirely off. Give me 10 seconds to kill this. So the distribution of eye pressure in glaucoma patients is a little bit higher, but look how many glaucoma patients have normal eye pressures. In fact, in any population, it's half or more of open-angle glaucoma patients will never in their life have a pressure above a magic number that I'm not going to say the number of.
And does they get more?
Yeah.
And does they get more significant in Asia, or is it about the same picture?
And in this Hispanic American population, it was 75% had pressures always in the normal range. In Japanese and Asian persons, it's 80 to 85%. Now, their eye pressure is still important. The higher their eye pressure is, the more likely their glaucoma is to exist in the first place, and the more likely it is to get progressive. So it isn't that the eye pressure is irrelevant. It's an important risk factor. It's the thing that we treat in glaucoma. But please stop thinking that if the number is below a certain number, you don't have to look at the disc and do a visual field test. And please stop telling people that there is something called normal tension glaucoma, because intraocular pressure at normal levels is so common in glaucoma that it's not a different disease. The phenotype, how it looks in terms of the disc and field, is so similar with those with normal pressures and higher pressures in glaucoma that you can't separate them except a little bit in terms of how the disc and field look. And I see so many people who've been told, oh my God, you got that dread low tension glaucoma, you're going blind and nothing can be done about it. I have patients every week who still come and tell me that. It's malignant behavior on the part of eye care professionals to tell a patient with normal pressure in glaucoma that they're different. And in fact, the data now show that if they are different, they actually have a less aggressive disease. You're worse off with glaucoma and a pressure of 30 than when you have glaucoma and a pressure of 15. You will be less likely to go blind. And we now have so much data that that's the case that it's really criminal that those of us who learn differently, because I was taught differently. Ed Malmany taught me, oh, they all have high pressure. You just have to send them home with a tonometer, and you'll catch them having an eye pressure that's high, and that'll prove they have glaucoma. No, those who have glaucoma at a pressure of 15 have an eye that is susceptible to being injured by 15, and lowering them to 11 or 12 is beneficial, and it works. So what I was taught was wrong. Don't separate them into high and low tension glaucoma. Now, what is this disease? Why is glaucoma as an eye disease different from a pituitary tumor? And it's because of what you're looking at right there. It is the physical change, the configurational change that happens in the disc that gets called cupping. I like to actually prefer to call it excavation because it looks like I took my finger and pushed the disc back. It also looks like I could stick my finger in under the disc rim. There are some few normal discs in the United States, they happen more often in African Americans, that simulate this excavated appearance. Like you could put your finger in under the ledge, but their nerve fiber there is normal. They were born that way.
Harry, they tell me if you raise your microphone clear up to your collar, the feet.
If they do, then I'll choke. Oh, okay. Is that better? And the feedback stops? Good. Now, what's the histological basis of this thing called excavation? When the disc gets that appearance of looking deep and undermined, two things cause it. One is you lost nerve fibers. There's the nerve fibers, and this is a monkey, but it is an induced glaucoma that looks just like human glaucoma. The nerve fibers are gone. That's a blood vessel. Very little nerve tissue coming over the edge. But if you only had lost nerve tissue, you wouldn't have that, the thing sinking backwards. So there is a change in the configuration of the connective tissues of the optic nerve heads, lamina cribrosa, and the peripapillary sclera, which moves sideways out. Now, there are some very similar optic neuropathies in terms of how the visual field is affected, called anterior ischemic optic neuropathy of the arteritic and the non-arteritic types. And the field looks the same as glaucoma, but the disc doesn't. These are average-looking HRT pictures. The cup is red here, and the outer lining of the disc is green. And what you'll see, what I've done is match up the same amount of field loss in glaucoma on the left and the two kinds of ischemic neuropathy in the middle and right. And you'll see the cup is dramatically smaller, despite having lost the same number of nerve fibers in ischemic optic neuropathy. And the reason is that in glaucoma, you not only lose nerve tissue, illustrated here in blue in the prelaminar portion, but the laminar portion of the optic nerve head compresses and rotates outward. Whereas in the person with anterior ischemic optic neuropathy, the connective tissue part of the optic nerve head just sits there. The nerve fibers melt away. There's less blue stuff, but you don't get this deep and undermined appearance. Now, there's paper after paper in the literature of, I once saw a case of anterior ischemic optic neuropathy. It looked just like glaucoma. Yeah, if you look at 100 of them, there'll be one of those and 99 that don't look like glaucoma. But for some reason, we like publishing the unusual, the different. But the general rule is not that. Now, some time ago, Zeiss Meditech figured something out, and so far as I know, I think the Heidelberg company is the only other one that's figured it out. And that is that when humans look at the optic disc, and we say, where's the edge of the disc? And we see this pink color, and then the pink color stops, and either white or brown pigment epithelial stuff starts, we say, that's the edge of the disc. If you set a crowd of humans, glaucoma pseudo-experts, to marking with little green dots, where's the edge of the disc? And then you use the newest form of OCT, SD-OCT. And you say, where is the edge of the optic nerve head? Well, the place where nerve fibers get into the eye is the edge of Bruch's membrane. They can't go through Bruch's membrane, they can only go around it. So the edge of the optic nerve head, in terms of true histological anatomy, is where the Bruch's membrane opening is. And it's a circle or an oval. So if you say to the machine, tell me where the end of Bruch's membrane is, and then you say to a human, put some dots down where you think the end of Bruch's membrane is, where the disc is, they won't match up. And they can be dramatically different from where they should be. Here's a picture. The disc margin, where a human would mark it, is given here in one color, and the actual position of Bruch's membrane on this human optic nerve head is in the red dots.
So are there cases, exceptional cases, where Bruch's is not the limiting factor?
Well, if you had an absent Bruch's, if you had a cracked Bruch's membrane, if you had a really, really tilted, unusual, distorted megadisc, or somebody with one of those horizontally oval tilted discs, I think you're screwed no matter what you do. You really can't tell. And all you can do then is look out in the retina for the number of nerve fibers, which you're going to do anyway. But if you're going to depend on looking at the cup-tube disc ratio or the rim area of the optic disc, you're going to have to take account of where Bruch's membrane actually is. So the two companies that are doing this now are no longer telling you that they are looking at the color appearance of the optic disc. They're actually looking for the edge of Bruch's membrane, the end of it being where you see there, where the red dot is. Now, where the human marked it in this particular eye was way over there. You can see Brooks' membrane went well beyond that. So that's step one. You have to start with where's the edge of the disc? It's where Brooks' membrane opening starts.
And in general, the disc will be estimated to be smaller if we do it this way.
In general, the real disc is smaller than you thought it was.
But there are exceptions.
Now you want to measure the rim area. Well, the standard way it was done with the HRT instrument for years, the way humans have done it for years, is you start from the edge of Brooks' membrane and you generally mark it horizontally from there, parallel to the plane of Brooks' membrane. Well, but discs are often tilted. And if you look at where Brooks' membrane ends, you could measure the nerve fiber layer from here to there, from here to there, from here to there, and you get a dramatically different distance, which is how you then integrate it into the whole rim area. But which is the right one? Which direction should you measure from here? And the answer is you should measure the least distance you can measure from the end of Brooks' membrane to the nerve fiber layer, at whatever angle it is. And when you do that, you get a very close match to whether the patient has glaucoma or is normal. And Bal Shahan, who works here in Canada at Dalhousie University, and my colleague, Claude Burgoyne, have written a couple of very, very important papers on this subject. So please read their work on why it is more sensitive and specific to not only use the edge of Brooks' membrane opening, but also to use the minimal nerve fiber layer distance measurement from the end of Brooks' membrane as the way to measure the amount of nerve fiber tissue that's in the disc. Now, as we look at the disc itself, remember that first histological slide, you're looking at the combination of both nerve fiber loss and connective tissue change. The connective tissue change changes with eye pressure. It changes with reorganization of connective tissue. It is not always the same as how many nerve fibers you lost. So if you're just looking at the nerve fiber layer in the retina, you're looking at the number of nerve fibers. If you're looking at the rim area and cup to disc ratio, you're looking at the combination of connective tissue change and nerve fiber loss, and the connective tissue change can miraculously improve. I did 6 trabeculectomies Thursday. Some of those folks next Monday or Tuesday are going to have a smaller cup disc ratio than they had right before surgery. Did I put back nerve fibers? Boy, would I love to do that. Not yet. We've got stem cells in the lab. We can answer questions about stem cells at the end if you want. But they aren't going in humans. What happened was the lamina cribrosa subsided back forward as the eye pressure dropped, and actually the eye got smaller, because the eye gets bigger when the pressure goes up and smaller when you drop it. So that smaller cup disc ratio is happening as a wonderful phenomenon, but it doesn't mean the patient actually got better. It just means the cup looks different.
So have you looked at AROCs of RNFL versus optic nerve and compared them?
There is, it's interesting that what Mike's asking is, can you tell whether or not just looking at nerve fiber layer is better than looking at the disc? When I first did it in 1990, without all the wonderful new machines we have now, by looking at the clinical nerve fiber layer and the clinical optic disc. And the present data with OCT, to the extent that it exists, has confirmed what we did way back then. And that is that looking at the nerve fiber layer is either the same as looking at the disc or better, but it's never worse.
We find they're about equal with the current technology.
And that's what, basically we're agreeing, because the problem with the nerve fiber layer is that the signal at any given point is highly variable from human to human. And the amount of signal against the amount of noise in the measurement you're making isn't big enough. So the nerve fiber layer's weakness is our ability to tell how many nerve fibers there really are is not as terribly good as we'd like. The weakness of the disc measurements is you've got lots of variation. I mean, in this room, you've got discs that are nice and round and small, discs that are huge, discs that are tilted, and the machine's trying to figure out all those things. And the problem is, as we'll see in a few minutes, the machine has a normative database which automatically excluded all kinds of strange discs. Except when you in your office do an SDOCT on somebody. You're not excluding the strange disc patient, they're in there. So now the machine looks and says, I never saw anything like that before. Mike didn't put that in the normative database. He excluded all the -5 myopes. And you got a -8 myope in front of you, and the machine says, abnormal. No, it's not. Patient's only abnormal because that's not in the normative database. So if you look at a disc, which one of these two discs has glaucoma? Well, which one has the largest cup-disc ratio? That guy. Which one has disease? That guy. This is the field test of that person. The person also had a disc hemorrhage. It's sitting right down there. This is a Hopkins Medical School faculty member who came to see us for getting reading glasses. And fortunately, somebody saw the disc hemorrhage, and that cued them to do a field test. And when they did, they saw the inferior nasal field defect, which was due to a loss of nerve fiber layer in the upper area in this particular person. And why does it not have a big cup? Because it's a small diameter disc.
And tilted. You wrote the book on looking clinically at RNFL. That picture is a great teaching slide. You want to say something about that?
Well, if you're not used to looking at the nerve fiber layer clinically, it won't impress you that this looks like white striated lines and there's none up there.
Yeah.
That's what Mike's pointing out. And we could see this in clinical color pictures forever. We took black and white pictures, which showed it, and for years I tried to teach that as a method of clinically examining the nerve fiber layer at the slit lamp. And you can do this. I teach every resident who works with me how to do it. But then the SDOCT machine is so much better than even I am at looking at the nerve fiber layer that I'd much rather teach them how to interpret the SDOCT and use the clinical exam to confirm that the OCT was right. Because you've got to do that. You can't listen to the machine. It's going to fool you maybe 10% of the time. And we'll show some examples of that. This is the range of normal disc diameter in this room. 5% of you have a disc that small, and 5% of you have a disc that big, and the rest of you are in the middle somewhere. So imagine the cup-disc ratio that would fit with those two if you jammed the same number of nerve fibers through both nerve heads. This one would have no cup, and that one would have a 0.6 cup. Except that's not reality. You don't all have the same number of nerve fibers. People who have this size disc have fewer nerve fibers to start with than people who have that size disc. And the reason is that embryologically, the nerve fibers were there first. And then God built a nerve head around it. You don't have any sclera when the nerve fibers went out heading for the brain at the end of the first trimester. So if you started with a lot of nerve fibers, you'll build a big disc. So larger optic disc diameter eyes have many more retinal ganglion cells. Now when they get wired up in the retina, those of you with small numbers of ganglion cells wire yourselves up so you can still have a normal field. It means each ganglion cell is doing more work. But it also means that you might be more susceptible to getting damage that's impairment because you have fewer ganglion cells in reserve. So it's bad to have a small disc, right? Nope. The actual risk factor for glaucoma is to have a big diameter disc because it's even worse to have a poor biomechanical disadvantage of a big hole in the back of the eye. So there's a very slight tendency for those with larger diameter discs to be more likely to get open-angle glaucoma. But the reason clinically it's important is you shouldn't look at a 0.6 cup and say only that it's a 0.6 cup. You got to look and see, is it a big disc? Because big discs ought to have a 0.6 cup, and small discs should never have a 0.6 cup. And how do you know how big the disc is? Oh, well, the SDOCT machine tells you. It'll tell you the disc diameter, and that's on the printout, and we'll look at that in a few minutes.
And the normative data are stratified by disc size.
And now they're trying to correct this for you so that you won't make that mistake, but it still is worthwhile looking at that. Bear in mind, too, you're supposed to be, with some instruments, putting more information in to get a correct disc diameter. Does Cirrus ask you to put in K readings and axial length?
It doesn't. We did that experiment and didn't get very far with it. It didn't seem to help as much as we hoped.
But with another instrument, with Spectralis, they're asking you to actually do an IOL master to get K readings or to do K readings and put them into the machine, and then the diameter measurement will be better. You know what I do clinically? I look at the disc, and this is an average size disc, neither a big one or a small one. How do I know that? Well, I look and see, does it look to me like the whole disc is filled up with blood vessels? Let me show you these two discs again. Can you see that it looks like that whole disc is just full of blood vessels? There's no leftover space. Whereas over here, the blood vessels are lonely. They're all grouped around the outside, and there's all this big cup space and rim space. So if you look at a disc and it looks like there's nothing but blood vessels, that's a small disc. And if it looks like there's just tons of wide open space like Canada, then you know it's a big diameter disc. Now, here in Ontario, 50% of those with open-angle glaucoma are undiagnosed. Shame on you. In East Baltimore and Baltimore, Maryland, 50% of glaucoma is undiagnosed. Shame on me. Why is that? It's not because these people aren't getting eye exams. In populations, except for the most disadvantaged populations, people are getting eye exams regularly from you all and from ophthalmologists. We're missing the glaucoma. Now, why are we missing it? We're missing it because we're using magic numbers. We're not suspecting glaucoma often enough when the eye pressure is normal. When we're looking at a disc and the cup doesn't match the size of the disc, we're not doing the OCT or the visual field often enough. And we're abominably not doing gonioscopy. And when we are doing gonioscopy, we must be misinterpreting it. The failure to gonioscope by ophthalmologists in the United States in Medicare billing databases comes out of a very simple fact. If you look at how many persons are coded as open-angle glaucoma compared to angle closure glaucoma in the US Medicare database, the ratio is 30-to-1, open-angle glaucoma to angle closure. The rate in the population in prevalence surveys that are definitive show it ought to be 5-to-1. So that can't be the right rate. And the only reason for that must be that we're not properly gonioscoping and identifying angle closure. Hey, what's wrong with that? What's wrong with that is it's a much more morbid disease. Angle closure patients lose more vision, they lose it faster, they have higher pressures than do open angle glaucoma, and they need an iridotomy when it's appropriate. So the fact that we're not gonioscoping, we did a chart survey that showed that ophthalmologists in the United States, about 25% of them, when in the days before electronic medical records, they had a paper chart thing. You may have one in your office. You know, it's got the history, and it's got the slit lamp findings, and it's got the fundus exam, you've got the refraction, you've got pupil, is there an afferent defect? More than 25% of them, there wasn't even a place on the form to put gonioscopy.
Were these clinics, private clinics, universities?
This was a random selection of ophthalmologists' Medicare charts.
Got it.
300 charts. They weren't planning on doing gonioscopy because it wasn't on the form. Well, that's unacceptable, and we got to sue. Sir?
Is evaluation of the angle by OCT considered to be a replacement for gonioscopy or only supplementary?
So the question is, can you replace gonioscopy with OCT? And the answer is no. And there are a whole variety of reasons for that. We don't have yet an instrumented way that accurately reflects what's going on in gonioscopy first. The second is with OCT, you see only one small segment of the angle at a time. The third reason is you need to do it in a way that you don't illuminate the pupil when you do the test. In other words, you need to do it in the dark, because if you illuminate the pupil while you're doing gonioscopy, you artificially open the angle, and you miss those that are narrow. You also can't see PAS. You also can't see in the narrow ones which ones have PAS, because I can see in about 38 seconds the whole angle by looking in a 4-mirror gonial lens. It would take you hours to do that with OCT. Now, will we ultimately have some form of OCT that helps, that replaces gonioscopy? Possibly. But I think we're not trained to do gonioscopy properly in our training, and I think we feel uncomfortable with it, and so we blame it on the patient and say, well, the patient doesn't like gonioscopy, so I'm not going to do that. You know, they all blint and squeam, and they don't like it. Oh, it's terrible, you know. But everybody does CCT. Everybody in this room measures CCT. Every ophthalmology chart we saw had a central corneal thickness measurement. And you can't blame it on finances, because in the US, you get reimbursed the same for doing gonioscopy as you do for CCT. So and you get money for it. So why aren't you doing something that you get money for? Why are you doing one of those things you get money for but not the other one? Because CCT is easy. Your technician can do it, or you can do it quickly. The patient doesn't mind it, and it's a number. I can see it. I can interpret it. In fact, I can wildly overinterpret it, and that's what's going on right now. And people are saying, I have to correct the eye pressure for the CCT. Jamie Brandt, who brought all of our attention to central corneal thickness in the ocular hypertension treatment study, has written paper after editorial saying, please God, people, stop correcting the eye pressure. because each individual human has a different relationship of CCT to eye pressure. The relationship is not linear, it's exponentially different. So you can't say I'm going to raise it 2 millimeters or lower it 3 millimeters for every so-and-so microns of CCT. Do take account of the thinness or the thickness of the cornea.
So three categories?
Sorry?
3 categories?
Well, you can categorize it as thin, thick, or normal range if you want. The persons with thinner corneas are more susceptible to glaucoma. That's true. But please don't correct it, because when you send the patient to someone else, they're going to look at what you did and they don't know what the pressure was in their office because they may not correct it the way you do. So we have all this problem with undiagnosed glaucoma. Who can you find tomorrow from your practice who has undiagnosed glaucoma? And the answer is family members of your glaucoma patients. Yesterday, I saw a lady who came to see me. Her mother has been my patient for 20 years. She knew her mother had glaucoma, and she developed headaches in January. In fact, the headaches had been going on before then, but she hadn't done anything about it, and then she saw her internist who said, you have migraine, and so now it's April. And she's got a gun barrel field and a pressure of 56 in one eye, and 37 in the other eye, and closed angles. She had come to see me with her mother multiple times, and I look over always at the family and I say, have you had a detailed eye examination with a visual field test? Because a family member of glaucoma, you have a 25–30% chance of having glaucoma. And she'd said yes. She'd had detailed eye exams by somebody who didn't gonioscope her, and I don't think she even had her eye pressure measured. And when her headaches started, they were headaches, it wasn't eye pain. You have in your office, for every 8 glaucoma patients you see in your office, there's 1 undiagnosed family member with active glaucoma, open angle or angle closure. And you can help those folks by insisting that they actually get a detailed exam or by doing it yourself. And that doesn't mean measuring their eye pressure. Oh yeah, I had an eye exam, my pressure's fine. It's not good enough. And so here's a lady who's blind in one eye and coming up to eye surgery because she didn't get the exam. So help the family and chase them down.
Let me argue with you a little bit. Can you back up?
Sure, absolutely.
One picture? I think it's
even
one.
though you're wrong, you can back up.
Yeah. Am I backing up or you?
I don't know. That's where to help the family. Where'd you want to go?
Well, I wanted to go to that picture.
Yeah.
Which I will argue that clinical skill is not passé. And look, what does that picture tell you that it wouldn't tell the average person? You put it up there for a reason.
Well, I did. I mean, the nerve fiber there is normal, so this is actually a physiologic cup. But
you think it's physiological? Okay.
But it could be glaucoma.
I was looking at the upper vein, saying, "Gee, that looks pretty proud of any."
Right there.
Well, I was looking at this whole length and saying, "I'm seeing that awfully well."
Right. So Mike's suggesting there might be nerve fiber loss there. Could be. I showed you the picture because that's a normal to slightly less than normal disc with a 0.6 cup. And the chance that that's normal in the population is about 3 or 4%, and the chance that it's glaucoma is maybe 25 or 30%. You get that kind of average, you should do a field test. And if it's abnormal, you do another one, because many people have a first field that's abnormal, and you have to repeat it. Okay, so who's getting drops? Now, I don't know about Canada, but I'll be willing to bet you a lot of money it's the same in Canada as it is in the United States. And half of the people who are being prescribed eye drops in the US have open-angle glaucoma. The other half are ocular hypertensive glaucoma suspects. We don't know, and that is also true in Australia, in the Blue Mountains Eye Study. We don't know how many of the ocular hypertensive suspects actually should be treated. We know it's beneficial. We also know they're very low risk in general. And Steve Kimes and my colleague Mike Boland have just published a paper that says that the average risk 65-year-old ocular hypertensive will never be impaired in their lifetime enough to be treated. You should just monitor them. But I think this is an individual decision you make with each ocular hypertensive suspect as to whether they receive therapy or not. Now, I don't think the therapy they receive should be surgical. It might be laser, and it's often eye drops. The average risk for the ocular hypertensive suspect, and now here we are talking about the person who has the pressure above the magic number and who has no definitive optic disc or visual field damage. So the odds that this person is going to, in the next year, develop an initial field defect or an initial change in the optic disc that truly represents a glaucomatous disc change, that risk is 2% per year on average. So it isn't that the person has a risk, they have a risk of a certain time length. So if you got a guy who's my kind of age, in fact, a couple of the speakers here's kind of age, he's expecting to live to be 82 years old, actuarially. Now, with a pressure of 26 and a cup of 0.6, he's going to live 17 years times 2% a year. That's a 1/3 risk of the field defect you're looking at there in one eye, untreated. Treat him and the risk drops by a little over half. Would I be able to play tennis with that in one eye and a normal field in the other eye? Oh, yeah. Now, would I want to have that field defect? No. So you can look at it. It's for you. You want to look at this. When I give lectures to the medical students, I start the lecture by saying, if anybody's cell phone goes off during this lecture, I will jump off the podium, come up there, and step on it. So please turn off your cell phone.
He used to threaten to answer it.
Yeah, well, then they have to give 6 answers to the next question. We just try to embarrass them a little bit. So that's the real risk for the average patient. Now, not everybody has the average risk. If I were 45 years old instead of 68 years old, I would have 23 more years of exposure to this elevated pressure. And so here's a paradox. Older age is a risk factor for the development of open-angle glaucoma. But if you're younger, you're going to be exposed to this risk, if you have it at age 45, for many more years. I am more likely to suggest therapy to the 45-year-old ocular hypertensive than the 65-year-old. And I rarely suggest therapy to the 80-year-old ocular hypertensive. So why are the older persons more likely to get glaucoma? Because they've been exposed to the risk without you knowing it all of those years up until the point you first measured them at age 75. So yes, are they likely teetering on the edge of field loss? Well, actually, no, not that much more. So nothing wrong with treating a 75 or 80-year-old person. You know, I want to be a well-sighted 90-year-old still playing tennis, but my risk level is actually relatively low.
So is there a pressure that chills your bones, that you say, okay, now we're beyond ocular hypertension, we're into pathological pressures that I'm just going to de facto treat?
When you sit down with a patient to make the decision, Mike just froze to me. What I would answer to you is, no, there is not a specific pressure, because I can't do that. It isn't a pressure sitting in front of me, it's a human. It's the guy whose cell phone just went off over here. Okay, so what do I know about him? I know his cup to disc ratio. I know his visual field test, because I had to have done that and make sure it's reliable. I need to know his family history, if he has exfoliation or pigment dispersion, whether he has a history of trauma or not, whether his CCT is thin or thick. And then I talk to him, and I say, you know, there's 2 kinds of people in the world, sir. There's the person who's going to go to bed tonight worried they lost 2 more ganglion cells. And everything always happens to you. No matter what it is medically, you're the one that always catches the crap. I want extra protection. I buy a lot more liability insurance than I really need. I feel better calling my daughter every night to be sure that she got in. That kind of person, I'm going to treat. I don't care what their eye pressure is, 22 or 35. I'm going to suggest therapy to them, and they're going to try it. The other half of the world are the kind of people who think that the pharmaceutical houses are out to poison them. They're quite sure no matter what happens, everything on the list of drug side effects is going to happen to them, and it will, because they'll get a placebo effect. They'll think it's happening to them, right? Their hair fell out, they gained weight, their knees started hurting when they took latanoprost, which doesn't even achieve a blood level in their body, but they got all those systemic side effects. That person is much better off without therapy. So which are you? Pregnant pause. Well, Quigley, I came here to the Wilmer Institute to find out, you know, this big answer from the big dog, the guy who's supposed to know the answer. You mean you're asking me if I should be treated? The answer is yes, ma'am. Now, if you want me to make the decision for you, I'll base it on your overall risk. And that's what Michael Bowen, my colleague, did. He calculated the risk from all of the things, including the eye pressure. Now, when the eye pressure, as Mike just asked, gets into the 30s range, it isn't 2% a year. It's now 5, 6, 7, or 8% per year, times 10 or 20 years. You're talking about 100% risk of field loss untreated, on average. I have patients who've had pressures of 35 for years. I just saw her, Patsy D, lady I've been following since 1978. She runs pressures into the 38 range. She's got a 0.3 cup in a normal field.
Tough lady.
I want to know what her sclera and laminar are made out of. I am waiting, she knows, I'm waiting for her to donate her eyes. And I hope it doesn't happen for 15 years, but if it happened tomorrow, I'm going to be there with the bucket waiting. Because I want to know how she did that. It may be her ganglion cells can't be killed, and I have mice that are just like that. We have a mutant mouse mutated in collagen 8 alpha 2, that's what Decimase membrane is made out of. Mutated this mouse, and we thought it was going to be very susceptible to glaucoma. You can't kill the ganglion cells in this mouse. At the same pressure that the wild-type mouse does get injured. So there's variable in susceptibility. But what Michael did was to show doctors, first average ophthalmologists, and then members of the American Glaucoma Society. The great experts, right? There's 500 of them now. Showed them a patient list and said, okay, you guys got a pressure of 23 and a cup of 0.7 and a field with a PSD of X and the CCT of X. Would you treat them or not treat them? 50 cases. Then 50 more cases where they saw the findings and they were given the risk calculation in terms of percent per year likely to get worse from the ocular hypertension treatment study risk calculator. And what happened was they were much more likely to behave in the direction the risk calculator suggested when they saw what the risk calculator showed. So I think there's a value to seeing the actual risk of the patient, and I can tell you, you can't calculate this in your head. And the most important thing there, it turns out, is the value of the pattern standard deviation when the pattern standard deviation is still in the normal range. You know, you look at the PSD and there's no p-value, there's no black box, there's no x's over there, you go, oh, normal. A PSD of 1.0 is very different from 1.8, even when both at that age of that person are within the normal range. And we don't take that into account. What we act on, we found out in Michael's study, we act on the pressure. We behave as if the pressure is the most important thing, and we're much more likely to treat at 24 than 22. And yet the difference risk-wise between 24 and 22, not much.
Right.
So we've overvalued pressure and undervalued early field change. And let's say you've seen this patient, and the patient says, okay, doc, I do want to be treated, or you've decided to treat. You've just seen him once. Don't start treatment. Bring him back 3 times. And start the treatment on the 3rd visit. And here's why. Here's 3 patients, each of whom had a pressure of 25 at the first visit. These are real numbers from real people. And I said, we're going to start your treatment, but not today. Find a couple of days when you can come back. I don't care what time of day you come back. I know your daughter has to take day off work. Bring, 8 in the morning before she has to go to work. You can come at 4:30 in the afternoon. The tech will stay around for you to measure. I just need 3 measurements. So here's 3 measurements. This person, 25, was actually the average baseline. This person, 25, was the highest pressure they'll ever have in their life. She was scared, white coat fear, whatever it was, bad day, too much coffee right before. And her real pressure average was 21. And this one, 25, was a lucky number because the average pressure was actually 30. When you are going to set the target number for a person, it has nothing to do with whether they're normal in the pressure. It has everything to do with what the untreated pressure is. The average person you're going to treat is going to be treated for 15 years with eye drops. Are you going to base 15 years of therapy on one number in terms of the baseline? Does that sound smart? Resist the urge to start the therapy the first visit and measure it a couple more times. It is not that hard. Now you lower the pressure by a certain amount and you say, well, how much? The target has to be lowered by a certain amount. For the average ocular hypertensive suspect, you're going to lower it 20%. If they started at 40, 20% is not going to get you all the way down even close to normal, so you're going to lower it a bit more than that. This is what the ocular hypertension treatment study did. This is the target range from each of those baselines to each of those. However, many of us now take into account that if it's not an ocular hypertensive suspect, but somebody who has field loss already, this is the early glaucoma patient, you're going to take account of how bad the damage is. And the worse the damage is, the lower the percentage lowering of pressure. So if there's 0 damage, 20% is fine. If there's severe damage, you want 30 or 40% down.
And you're stratifying those because of the risk of aggressive therapy? If you
Because of the risk of impairment in their
Yeah.
lifetime.
Yep.
Now, some of this is going to have to be aggressive therapy. You can get 40% down with eye drops in some people. Eye drops and laser in some people. You don't have to do trabeculectomy on everybody. And I have great respect for my wonderful colleague Paul Palmberg, but everybody doesn't have to have a pressure of 12. You will hear some talks in which somebody says, well, if you get them all down to 12, nobody will progress. Yeah, you're going to blind a lot of people with the therapy, surgery. And by a lot, I mean across a whole population of people. If you blind 2% of the people trying to get them to 12 and you treat the United States population that way, you will blind as many people as would ever have gone blind from the glaucoma untreated spontaneously. So we got to be careful about what we wish for when the therapy itself has side effects. I do unilateral eye drop trials, which means that on that third visit, I say, now you're going to take this drop in the left eye once a day or twice a day, and you're going to come back and let's see what happened. Tony Riolini, a very smart colleague of ours from West Virginia, has written several papers that unilateral drop trials are far from perfect. I mean, he says you shouldn't do them. That's silly. The two eyes are correlated with each other, but not completely correlated. So the untreated eye is a pretty good control, but not a perfect control. Start the unilateral drop trial and continue it for 2 visits. By that point, the correlation between what the 2 eyes did, untreated and treated, should tell you the story. How much pressure lowering am I getting on average in the treated eye? It also tells you about side effects. If you start drops in both eyes and the patient comes back and says, my eyes are all itchy, you don't know if the pollen count's been high for the last 3 weeks or whether they're getting a drop side effect, and neither do they, but they're going to blame it on the drop. For sure, they're going to blame everything on you. When I do surgery for glaucoma on a patient, almost everything that happens to them during that month and thereafter, doctor, it must have been that surgery you did. Which is natural, it's human, we live with that. We treat people, we have to live with it, but unilateral drop trial says if both eyes are red, ma'am, the latanoprost didn't cause the untreated right eye to get red. So that helps me out in that. But then when it's working, if it's achieved the target, then we treat both eyes.
So why is
Make sense?
Tony so emphatic about?
Well, Tony says that the correlation, if you look at people's 2 eye pressures, when you didn't change anything between visits, they don't hit within a millimeter of each other about 1/3 of the time.
Yep.
Tony, they hit within 1/3 millimeter of each other 2/3 of the time. Right? So, you know, it's one of these things where it's great to be a curmudgeon and say
Well, Tony's
that
that.
doesn't work and you better be careful. He's right. You be careful. The untreated eye can occasionally go the opposite direction that you're expecting, but by the time you've done 2 visits, that correlation gets so good that it's really useful. Okay, so, sir.
Can you speak, you started going on, I couldn't get this in, but the applicability of the oath calculator we can use online. Like I use one on my iPad and
Right.
you plug in the 5 pieces of data and it spits out a percentage risk within 5 years. I think it's a great way to help guide a patient in making a decision. Can you speak to the applicability of that, and is this something I'm at lunch on, or is this something that has viability?
No, we have the oath calculator on the computer in the office. We're running an EMR called Epic, and then you bail out to Chrome or Explorer or whichever browser you're using, and you can call up the oath calculator from the Washington University website, put it on your office room computer, and put in the patient's pressure, CCT, cup disc ratio, and I think the PSD, right? And it will give you a percentage. It will say in 5 years, so that 2% per year I'm talking about, it'll give you the 5-year rate. So instead of 2%, 2 times 5, 10, right? So if the person has a 3% 5-year rate, boy, that's low. That might lead you in the leaning patient or the you're leaning one way or the other. If it says 22%, you're talking about a very high-risk person, and I'm much more likely to treat. And that's the study Bowman did, was to use that. Now, you don't live and die on formulas and numbers, but I think we can inform our decisions based on those kinds of numbers.
Is there more than one of these calculators? I'm thinking of Steve Mansberger's original
Yeah,
one.
Mansberger has one. They updated the one that's there based on the European Glaucoma Society stuff. And the only proviso here is if your patient has exfoliation syndrome. If your patient is Asian. There weren't any exfoliation or Asian persons in the original oath study, not to speak of. So you might say, well, I don't know that that's really true of people with those features, and that's correct.
There's an app for it.
And there's an app. There's always an app for everything, right? So which drop do you choose? You've decided to treat the patient. You would almost certainly begin with prostaglandin, but you need to tell the patient a few things. First, that it's the most potent drug. You only have to take it once a day. There are minimal side effects, but some of the side effects are things you may not want to have happen to you. If he fell in love with you because you have blue eyes, and if your eye color changed, that's the end of the world, then you're going to try a beta blocker. You're not going to try prostaglandin. If you'd like to have great big eyelashes, this is the drug for you. And you might get what this lady's got, and that is orbital fat atrophy, which we're recognizing a bit more now. Most of the patients I have who have this think that I did plastic surgery on them, and they're delighted. They got less, this folding over goopy stuff here that I got to, and this is, and they don't mind. However, some have considered, especially when they're being treated unilaterally. This lady was being treated just in her right eye.
Is this
Now-
reversible?
No.
If it's not.
No. The pigmentation of the lower eyelid skin reverses. And by the way, it is not necessarily only European-derived people who care about the pigmentation increase in their skin down here. Brown-eyed people will never get a noticeable increased browning of the iris. But the darkening of the skin under the eyelids, my persons who are persons of color really mind just as much as the persons who are European-derived. So tell everybody about the eyelid turning color. And that will reverse over 2, 3, 4 months, but not the iris color change.
And the
If you
orbital
get-
fat?
Say again?
I was
The orbital
asking-
fat doesn't go away that anybody's been able to see either.
Yep.
And that's an interesting question. We're presently looking at the effect on the sclera of prostaglandins because we're doing sustained release that I'll talk about. Second line drugs, almost surely it's going to be beta blocker. They are cheap, as are in the United States. I assume that you have generic latanoprost. I assume you have generic beta blockers here. And the joy is that almost all of our agents are now available generically. So why are the companies producing new Alphagan, new Lumigan, preservative-free drugs? Because they don't have to develop a whole new drug. And now it's back on patent again. And now it's back costing $130 a watch, So that's what's going on. Some of them are valuable. Preservative-free drug do have a role. A little teeny role, but a role. And otherwise, use the low-cost drugs. Low allergy rate with beta blocker, please take a systemic history. Asthma, bradycardia, and dry eye especially. You must be very careful with persons with symptomatic dry eye, treating them with a beta blocker.
Do you think about using preservative-free drugs in people that you think you're going to have to take to surgery? Is that an issue?
You have to. I mean, almost all of our patients who go to surgery have been medically treated. And you don't start out with preservative-free drug because it's inconvenient in the little, daily thingy-doos, and they're very expensive. Maybe their pharmacy plan won't pay for it. I don't know about the Canadian system, whether you're allowed to. Are you allowed to use preservative-free drug here? Do you know what it is? It's made by Merck. There's preservative-free Cosopt, and there are a couple of forms of Timolol, and there's a preservative-free prostaglandin. Now, if you're sure the patient's allergic to benzalkonium chloride, there are non-benzalkonium preserved agents, Alphagan P, Travitan Z, and there's also preservative-free drug. And an occasional patient who's got red, angry-looking eyes, when you switch to the non-benzalkonium containing drug,
So you're not going after these to keep the conj pliable.
I would love to keep the conj pliable, and there's no question that medical treatment does increase the inflammation and probably the scarring in the conjunctiva. There is no definitive evidence that treating actually decreases the long-term success rate of glaucoma surgery, but it definitely increases scarring. There are so many factors in whether glaucoma surgery is successful that one factor is not a dominant one. Not with mitomycin C added to trabeculectomy. Here are 2 third-line drugs. This drug, there is a paper that suggests that this drug has an effect that's beyond its pressure-lowering agent in protecting retinal ganglion cells. There's not a serious glaucomatologist in the United States who believes that paper. There are so many things wrong with that paper that it is unfortunate that it was published, and I think it's something that got there for reasons that are not scientific. That's as far as I'm going to go, and
We get it.
I get sued if I go beyond that. So alpha-GAN is a fine drug. It has a spectacular allergy rate. Even in the trial that I just talked about, more than almost a third of patients couldn't continue the drug long enough to finish the study because of intolerance or allergy. None of our other agents have anywhere near that rate of intolerance. If you have a patient on multiple glaucoma drugs and they call you on the phone and they say, my eye is red and itchy and the eyelid skin is scaly, you say, stop the brimonidine. Stop the alpha-GAN. It'll go right away. I don't care, whoa, I think it might be the latanoprost. No, it's not. It's the brimonidine, until proven otherwise. Okay, let's talk adherence. If you have a patient who starts in glaucoma therapy and you give them a prescription for the drug, the chance they'll still be taking it at the end of the year is 50%. It's terrible. And you say, well, that's not my patients. My patients all keep taking their drugs. Do you know why you think it's not your patients? Because the 50% who stop taking it don't come back. The ones who come back are probably more likely taking their drug. We've shown that. But if they're not coming, we say no visit, no drop. Patients who are skipping their visits and you have to call them to get them to come back in at 18 months and 2 years, they're definitely not taking their drop. And we now have monitored the drop use by putting a computer chip on the bottle to know who's taking their drops and who's not taking their drops. So let me tell you about some of that data. First, if you say to a patient, you're taking your drops, aren't you? 95% of them are going to say, oh yes, doctor, I'm religious about my drops. If I hear the word religious one more time, I'll vomit. I'm religious about my drops. 95% of them say they're taking 95% of their drops. Doctors think patients are about 80% compliant. The answer actually is, in true studies with monitoring electronically, my patients who didn't have to pay for the drug we were giving them in this study and who knew we were monitoring them with a computer chip took 72% of their drops.
So why don't we laser more people?
We offer laser to a lot of people. You should be talking to every initially treated patient about, Mrs. Jones, we've determined your baseline pressure on 3 visits and we've decided we need to treat your early glaucoma. There are 3 choices for treating your early glaucoma: eye drops, laser, and surgery. And you tell them what the 3 choices, risks and benefits are. A very small number of people will pick surgery. I just had somebody yesterday pick surgery as their first. I'm not going to take drops. Can't you fix this? Many, many more people say, well, no, I want to take the thing that might not, cause me to go blind. Laser treatment sounds good, very low risk. Success rate, cleanly achieving the target pressure for 5 years or more, 30% or less. 30% more get some lowering but still need to take an eye drop every day to get to the target, and 30% got absolutely no effect whatever from the laser. That's definitive data, and it's true of ALT and it's true of SLT. So while the laser is good, and I have people who choose laser first, and why not? Because it's pretty low risk. Now, I also saw a man, again yesterday, it was a big day. He had been treated with SLT and the doctor said, well, it didn't really work that well, so let's do it again. His baseline pressure was 25. After the first SLT, it was 28. And after the second SLT, he showed up yesterday with a pressure of 49. Oh, I thought SLT didn't do any damage to the eye. I thought you could repeat SLT. Yeah, you can, except you're injuring the eye, because it doesn't work if you don't injure the eye. The way laser angle treatment works is by micro-injury to the trabecular meshwork, releasing cytokines into the aqueous humor, which upregulate lots of good things in the uninjured part of the angle. And by the way, there are 3 publications showing ALT is as repeatable as SLT is claimed to be now. I wouldn't do second laser treatments on very many people for the reason this young man just found out. He gets a trabeculectomy on Monday because we couldn't even get him medically down. He's on Diamox for the weekend. So are patients taking their drops? Well, here's the electronically monitored adherence of 2/3 college graduate insured patients in my office, my patients. Veteran glaucoma patients, all of whom said, oh yeah, I'll be in a study, I'll prove to you I'm taking my drops. Check these ones out. This is an adherence rate of 1 out of 5 drops going in the eye. Lady down here said to me, that computer thing you put on my bottle doesn't work because I always take my drops. The computer must be wrong. Right? The poor adherent patients, though, always have a pretty good pressure the day they come see you because they don't take it in between visits, and then right before the visit, they start taking it again. We all do this. Would you go to the dentist without brushing your teeth that morning? Well, you might, but I bet you're more likely to brush than you are on the average morning, right? So humans do this. Now, bear in mind that the best adherers didn't have that pattern. There's a lot of people doing really well. The problem is, how do we find the people who are the poorest adherers so you don't waste a lot of chair time trying to get them to adhere? Because I'm not just going to tell you a sad story here, oh my God, nobody takes their drops. I've heard that story given by even a colleague of mine in Baltimore. That's not what you need. You need to hear, how do I find the patient who's poorly adherent and what can I do about it? You can fix it. Don't use the IOP and the visit as an adherence test. Just because their pressure is above target does not mean that they're not taking the drop. If you ask them if they're having side effects from their drop and they say, yeah, it burns and it's red and stinging, you might say, oh, well, they're probably not adhering. The people who complain about side effects are much more likely to be taking their drops. Having any problem with drops? No. Got any questions for me today? No. That person is twice as likely to be non-adherent with therapy. They don't want to hear anything. They just want to get out of your chair and out of the office so they can forget about you for the next 3 to 6 months and leave the bottle sitting somewhere. Persons who ask a lot of questions, people who are concerned because they have a family member who lost vision from glaucoma, 95% success rate, 95% adherence rate. To identify those people who are non-adherent, you can ask the following question. First, you have to open the dialogue a little bit. You're sitting there with all this fancy equipment. You might have a white coat on or you might not. But they have great respect for your competence. And they assume that they can't possibly know more than you, and they can't also possibly not be, they can't admit that they're not taking their drops, because what idiot would admit that to the person who has all this expertise and stuff? So you say, you know, it's really hard to take medicine every day. I myself, I tell this story probably 5, 6, 8 times a day. I myself have to take a blood pressure pill every day. And I have these little AARP Sunday, Monday, Tuesday, Wednesday, Thursday little plastic container, and I put 1 pill in there each day. And this week I look back on Thursday and Tuesday's pill was still sitting there. How could I have forgotten my pill? I remember now. The time I normally go to take the pill first thing in the morning, my wife screamed, the woodchuck's eating some plants in the garden, get the pellet gun. So I go running with the pellet gun naked into the backyard, trying to get the woodchuck. This is actually a true story.
That's why it's funny.
He's faster than me, even though I didn't have shoes on. He got away. I came back in. I'm running around. I eat breakfast. I leave. That's what happened Tuesday morning, so I missed my... But with a pill, I know it's still sitting there. Right? I can count pills. You can't do that with eye drops.
I got the video on YouTube if you want to see it.
But I say, you know, I missed my pill on Tuesday morning because I changed my schedule. It even happens to me. Do you think in the last 2 weeks, Mrs. Jones, you might have missed your eye drops once or twice? If the patient says, I never missed a drop, you don't know what they're doing. They may be adherent, they may not be. If they say, yeah, I think probably at least once or twice during the last couple of weeks I missed my drops. That's the 50% adherent patient. So that question, that little story just took me about 40 seconds if I do the short version. In addition, if you say to the patient, what's the name of that drop you're taking? And they can't even come close to saying latanoprost. For each drug I have a name. I say latanoprost. Sounds like the language Latin. Can you say Latin? That's your drug, Latin. Timothy. Timolol sounds like Timothy, right? Pick a name for each of those drugs. Now, the patient who can't name their drug, they're non-adherent. If they miss return visits, they're non-adherent. Your youngest and your oldest patients are the non-adherent patients, the 40-year-old and the 85-year-old. If they don't know someone who ever lost vision from glaucoma, and for a reason we have not been able to figure out all of the details of, our African-American patients in the United States are less adherent and more resistant to intervention. And this is independent of cost, socioeconomic status, education, and lots of other things. We are missing something to help our African-American patients that I have not yet figured out. And it isn't that I'm white and they're black, because we did a study with a black woman ophthalmologist, and her patients in a monitored study were no more adherent than mine. So either she wasn't communicating differently, or we need to get a message across we haven't figured out. And that's a very important area because of the much higher rate of morbidity of glaucoma in African-Americans. Now here's what works. You've now identified the person. You've said, gee, I know it's really hard to take your drops. Here's what you're going to do. Do you have a cell phone in your pocket, in your purse? Because if you've got a cell phone, I'm going to help you fix your problem. I want you to set the alarm on your cell phone to go off at the time of day you're supposed to take your prostaglandin. And I'm going to make you a bet. I bet in the next month it goes off at least 3 or 4 times, and you would have forgotten to take your drop. And every patient who's come back doing this says, oh my God, I didn't know how often I was missing the drops. You can use a cell phone alarm, you can use an alarm clock, you can buy a runner's watch for about $10 that has a daily alarm on it. We had an improvement from 49 to 67% drops taken electronically monitored by using robocalls. Mrs. Jones, you said you were going to take your drop at 9 p.m. It's 9 p.m. If you've taken your drops, press 1. If you have not taken your drops, go take your drops and come back and press 2. It worked. Statistically significant increase in drops taken, right? The Sharpies in the audience are going to notice that that's not 100%. People told us they'd just taken their drops, and the electronic monitor said, no, they didn't. They lied to the RoboCop.
And they knew they were being monitored.
Yeah, and they knew they were being monitored. We don't fib to people in these studies. But to increase from 49 to 67% would decrease the blindness from glaucoma in a population of people by about 15 or 20%. And it costs nothing. If the drug companies had any brains at all, they would institute a program where people voluntarily sign up to be called and they pay for the calls. And by the way, you know, did you need to talk to your doctor today? This sort of thing. They could be robocalls. It would be better if it was humans. Imagine $1 billion a year business, what it was during brand name Zalatan. They could have increased to $1.3 billion a year simply by about a $10 million a year phone call system, and they refused to do it. I think people at companies need to go to business school. Oh, you mean they did? And they don't teach that at business school. Oh, well, that's funny. Now, if you're interested in all the stuff about adherence, about helping patients, about patients saying, well, doctor, where can I read more about this? This is a shameless self-promotion for a book that I wrote for patients with glaucoma. It's available on Amazon. If your patient doesn't want to pay $30 or $32 on Amazon for the book, which tells them all about glaucoma, how to take an eye drop, how to get the eye drop in your eye. Doctor, I'm running out of drops before the month is over. That's because you're taking 3 drops instead of 1. You need to take just 1 drop. Here's how you take just 1 drop. So you don't have to spend more time than your average spending right now. You can say to the patient, you can buy this book, or you go on the Wilmer Institute website, hopkinsmedicine.org, hopkinsmedicine.org, Wilmer, Glaucoma Center of Excellence, patient book, and a picture of this book is there. You click on that, and you can read every chapter free. If you buy the book on Amazon, the royalties go to glaucoma research. So either way. Some patients like having a book. I've signed a bunch of copies of it. Okay. So now we're going to get to where Mike's bread and butter is. We're going to talk about fields and imaging and how to put the two together. And our total time is when?
We go to 11:10.
11:10, fantastic. Okay, we got great time. When you look at a visual field printout, and the printouts I'm going to show you and the SDOCTs I'm going to show you are Zeiss products, take that into account. If you use Octopus or some other fields, the general principles are the same, but the specifics are a little different. The field test, when you look at a field printout like this, you should go through something in your mind that says, am I looking at the test from the right patient? Did they put the date of birth in right? Why would that matter, date of birth? Who cares? The age against which the patient is being compared in the field test depends in the machine software on the date of birth that you put in. You don't want to compare an 80-year-old against 40-year-olds. You also have to have the proper correction in there. So look at those. That takes you about 3 seconds. Right patient, correct date of birth. Was the RX correct for near? Second, is the field test reliable? I'm going to make the argument there's only one reliability index that's any value whatsoever. It's false positives. It's not false negatives, it's not fixation losses. My colleague Pradeep Ramalu has just done a big study that says that the variability across time in a patient, which is a measure of how reliable the test is pretty unrelated to anything except high false positives. And it doesn't have to be enough false positives to ring Zeiss Meditech's little bell of putting X's over there. Almost any false positives are bad. 3-4% false positives, and that's a field test I'm worried about. I'm re-instructing the patient. You're over-responding in there. Relax a little bit. You don't have to try to see every flying gnat in the room. Wait until you're sure that you see the light a little more. Second, look at the grayscale to see, are you looking in the gestalt here of is there really a field defect in the general area over there? Then the total and pattern deviation plots tell you against age-normal data is the average thing showing abnormal points, and when you generally reduce the amount of diffuse loss, is there a pattern that's still left? Look at the glaucoma hemifield test, the mean and pattern standard deviation indices, the global ways in which they talk about the field, and finally, please God, turn on the foveal sensitivity test. The default setting is off. I've ragged Mike for years that it should be on, but they don't want to do that because you have to re-instruct them to look down at the 4 little yellow dots. The foveal sensitivity comes in handy all the time.
Say how.
The glaucoma patient who has only mild field loss, who has foveal sensitivity loss, they're going to have a macular hole, they're going to have age-related macular degeneration, they've got cystoid macular edema. You're thinking glaucoma. I did a field test. This is a glaucoma patient. You're not thinking, look at the fovea. Wait a minute, why is the fovea abnormal and only in the right eye? It's abnormal in both eyes if they just didn't understand the test, or you or the technical person explained it wrong. But if it's abnormal in one eye, now you're, oh, 20/25 minus 3 in that eye, 20/20 in the other eye. Now you're doing a detailed look at the fovea. You're getting extra information and finding things before the patient goes blind from AMD, where now they actually have some semi-good therapies for age-related macular degeneration. I use the 24-2 program. It's faster. It has fewer points than the full 30-2 program does. I don't believe I'd lose a lot only doing the 24-2. For severe loss, when the field is very constricted, you either switch to a 10-2 or a size 5 test object. I generally prefer the 10-2. The spacing between those, this is every 6 degrees between test points. The 10-2 is every 2 degrees. Mike?
What is your reaction to the discussions raised out of New York that we should be doing, in addition to 24-2, also 10-2 testing?
Yeah, the average patient has about 5 to 6 minutes of attention span and patience level for doing fields in an afternoon. So if you're doing bilateral fields, you will notice that the second field test is much more often getting to unreliability than the first one was. And the human that can go through a bilateral 24-2 and a bilateral 10-2 in the same day is a very special person. If you say, I want that done, you could alternate it. You could do them every 3 months. But doing them on the same day, I find is just exhausting.
So I think there's information in the observations. This is Jeff Liebman and Don Hood's papers in the last 5 years. However, I think the wisdom is not to double down on fields. It's to add something that looks at the macula.
It won't be terribly long before we have some pretty good data on matching up 10-2 field data on lots of glaucoma patients with their SD-OCT findings of retinal thickness and specifically the ganglion cell layer and nerve fiber layer thickness directly overlying where each of the test points in a 10-2 was, and putting structure and function together in that way. Generally, putting structure and function together is a good idea. Specifically, we don't have a way of actually magnifying the information that we have by putting them together. But 10-2 is going to be the way, and Mike knows we're working on that, and so is Jeff Liebman. So here's a patient's 24-2, and there's what was going on in his 10-2. And without the density of testing, you would not have known this. This guy was complaining bitterly about difficulty reading. And you look at that and say, there's nothing wrong with you. Yeah, there was. He's got major league detailed glaucoma field defect near fovea. This is not typical, but it does happen. Okay, the total deviation plot is really useful because it tells you what's actually statistically abnormal compared to the grayscale. Now, in this case, the grayscale and the total deviation plot look pretty much the same. But the total deviation plot has a skewed distribution of points abnormality. So you can't look at the raw value and tell something. You have to look at whether it's abnormal at a 5% or a 0.5% level. And of course, it gives you a probability symbol for doing that. The pattern deviation plot has an interesting way of removing some of the diffuse loss to say, well, is there still a pattern that's abnormal? Now, a lot of them, they look the same, total and pattern. So the defect didn't change very much by removing some of the sensitivity loss. But in others, it actually does. Here, you have a similar. Total, the local defect in the upper nasal area of this eye, same thing in the pattern deviation plot. That's a pretty typical glaucoma pattern. Here's one where most of the loss was diffuse, and while there's a tiny little pattern defect left there, most of it was diffuse. That doesn't mean it was something other than glaucoma, because glaucoma can cause diffuse loss. It's just diffuse loss is nonspecific, and it could be cataract or corneal opacity or sleepiness. Here's another one, a lot of diffuse loss, and this is a smashing local nasal defect in a patient with a lot of diffuse loss. Here's a pattern you have to recognize and realize right away it's an artifact. Whenever you have a clean as the whistle total deviation and abnormality in the pattern deviation plot, you're going to look up and find out the patient has high false positives, 17%, abnormally high sensitivity in the GHD. This is what we call the happy clicker. Patient's sitting in there and they're clicking the button. It has nothing to do with what's going on in the test.
I would take it further. If you're seeing this pattern, regardless of what you're seeing in these other metrics, you should be suspicious.
This patient needs to be pulled aside as soon as the tech sees it, if the tech sees it during the test, but certainly after the test, and you say to the person, you know, we really want to get some useful information out of your field test, and you're trying too hard. I want you to be certain the light is on during the, I don't care if you're actually giving me a lower than normal response the next time. I want you to be certain you see the light and make sure they're given the demo again as to what the target looks like off to the side. Mean deviation getting worse is not good. You might say, well, that's cataract. We did a study where we took out cataract in patients and we looked at the two fields before the cataract surgery and the two fields afterward. The average 20/40 removal of cataract improved mean deviation by 2 decibels or less. If your patient's mean deviation in glaucoma has gotten 5 decibels worse, it's almost never glaucoma. It's almost never cataract. It's glaucoma causing that. So be very, very cautious about interpreting mean deviation loss as, oh, well, that isn't glaucoma. Now, it's hard to be specific that that's glaucoma, but you have to be suspicious about it. The hemifield test is one of the smartest things that Anders Hale and Mike ever did. I say that because
we stole the idea. We stole the idea from Al Sommer.
Yeah, but Al Sommer had this idea of comparing clusters above and below the horizontal meridian. We've now published recently a software piece that compares across the vertical meridian called the neurohemifield test, and that works pretty well. Mike's going to put that on the software for us really soon.
That's right. That's right. You heard it here first.
That's right. I always put him on the spot in front of large audiences so that if he doesn't do something, he'll say, well, why didn't you do that yet, Zeiss Meditech? So the hemifield test is a really, really specific test for glaucoma and works extremely well. When it's outside normal limits, it's one of the main things we use to decide someone has early glaucoma damage. If it's borderline, and I think I got this right now, Mike, it's because one cluster is 3% abnormal?
Yeah, at least.
That's right. And abnormally high sensitivity is that happy clicker I was talking about. Nobody should have a mean deviation around +2. That's so unusual that it's an artifact and the patient's poorly responding. Now, if there's a general loss of sensitivity and the machine's not going to be able to give you a good upper-lower comparison, it'll say general reduction of sensitivity and you're off the map for using the GHD.
And it's not highly specific. It has a specificity of 94%, at least it's designed for that. So you need to keep that in mind. You're going to get 6% false positives in normal fields.
Every time you do a field test, you have 3 questions. Do I believe this is a valid test? In other words, was it done properly? And is it unreliable because of high false positives? Second, is it normal or abnormal? And if it's an abnormal test and you've done 2 or 3 and you know it's repeatedly abnormal, then your next question is it getting worse? So you have those 3 questions for any particular field. And if they're already abnormal, you only have 2 questions. Valid, worse. Rule of the first field. If the patient does a field test and all the criteria are normal, the first field, you can believe it. It's darn hard to do a normal field test. So somebody who succeeds at doing that, they're really normal. First field abnormal, repeat it. It's going to get better over time. Don't tell somebody who's only had 1 field test, oh my God, you've got glaucoma. You don't know yet. Now, we're now going to talk about progression, progressive change in fields. And here's a person who was clearly getting worse. And in looking at them, there are ways of doing that. Their glaucoma progression analysis software takes, in 2 ways, the comparison of 5 or more fields over time. You can do it with 3 or 4. The first is it will actually make a graph for you of mean deviation, or the newest form of the software makes a graph over time of the visual field index, which is similar to pattern standard deviation. Eliminates a lot of the diffuse loss, tries to look specifically at glaucoma. and has a pretty good track record of telling if the patient's getting worse, and it gives you a slope over time of those indexes. Here was the older mean deviation slope, and the second one is glaucoma progression analysis. It gives you an answer down here, likely progression in this case. Of course, I'm showing you an example of a dramatically progressive patient. What's the thing doing? It takes the first two fields, averages what the results are at each point, and then each subsequent field test is compared to those first two point by point. The machine knows how variable the average non-progressive glaucoma patient is and says if the point that you're comparing, 54 of them, is worse than the variability of a stable glaucoma patient, I'm going to tell you that point might be progressive in the third field. In the fourth and the fifth field, if that point has been beyond that limit of progression, the second time and the third time, the point gets a black triangle. Bad twice, half of a black triangle. Bad once, a triangle with nothing in it. If you get 3 points that are worse 3 times, the machine says, that's bad enough, I'm going to call this likely progression. Now, this system is good because it sensitively identifies the patient who might be getting worse. It's not so good because it doesn't tell you if points got better. The average person could have some that got worse and some that got better. And if I have an equal number of those that got worse and that got better, that's called staying the same. So why did they put that on here? Well, because it's better for you to worry over patients with glaucoma. Do you know the average glaucoma patient doesn't get worse that fast? The average glaucoma patient in their lifetime is not going to go blind, untreated. But there's so many glaucoma patients that having 10% of them go blind means there's a lot of blind glaucoma patients in absolute numbers. The average patient can be told on that first visit, when you've set the target and you've started the drop, you follow the program and you have a 95% chance of never becoming impaired in your lifetime. 95% chance. Instead of saying, you've got a blinding disease. I mean, they're going to go fill out their life insurance and get a gun. You can help the quality of their life by saying the treatment and medicines and visits that you're doing with me are going to keep your vision 95% of the time. Part of that's because the disease, on average, is not that morbid, and part of it is because the therapy works, as long as they keep coming back to see you. Some persons terrified by a blinding disease, best way they deal with that, they don't show up again. That's the no-visit patient. It's called denial. We all do it. We can't let that get in the way of keeping somebody's vision for them. So here's a patient. There's the first field and the next field. These are 1999 and 2002, 2003. Another one, it's truncated. It's another year or two. What do you think? There's 2005, 2006. So we'll look at a printout that shows this glaucoma progression analysis, likely progression. 1, 2, 3 black triangles. That's how it got it. And some that were worse twice. Obviously, you looked at those fields and you didn't need the software, right? I mean, the patient was getting worse. But I'm giving this as an example of how to look at that software. If you were using older software, the mean deviation was going downhill. And notice it went from -8 to -18. That ain't cataract. That's glaucoma. Now, the PSD was getting worse too, and so was the glaucoma progression analysis. Now, if you have the most recent update of the software, it's going to present you with the visual function index. This is a different patient, and it's showing that a visual function index looks pretty stable over time. If you say, well, how do I know it's stable? Because it's running a linear progression analysis. It says slope not significant. Down here, no progression detected. That's this field, the 6th one in line here against the 2 baseline ones. 3, 4, and 5 aren't on this printout, except as a VFI box. Here's a patient with 5 fields, starting there, 5th field here, slope significant, probability less than 1%, 2.4 decibels per year. Bal-Shahan calls this catastrophic worsening. There are about 5% of glaucoma patients with this form of catastrophic worsening. Here's the problem. Patient's first field was they were 60 years old. That field test, they were about 66 years old. It took us 6 years to figure out this patient was catastrophically worsening. We should have done more fields earlier here to detect that worsening rate. The message is do many more fields early in the first 1.5 to 2 years. When the patient's perfectly stable on those, fine, drop back to once a year. Patient who in the first 5 fields is going down by a decibel and a half, 2 decibels a year, that patient needs aggressive therapy. They're not taking the drops aren't working, they're probably going to get surgery.
What fraction of patients do you think fall into the catastrophic category?
5%. It's a minority, and we don't yet have all of the risk factors for it. Again, Jeff Liebman's doing a really good job at looking at some of those risk factors. Patient comes and they've just done a field test that day, and this will be 6, 8 times a day in the average practice. I want you to sympathize with them about how tough that field was. Really thank you for living through another field test today. Well, when you come back in 6 months, I know your favorite thing is going to happen. You're going to get to do a field test for us. And and they moan. You say, but you know how important it is to us. You know how that's how I tell that you're stable, that you're getting your drops in, and you're remaining safe. I know the test is hard. They say, I know I did terribly today. Well, the reason is the machine is taking them to what they can just barely see and then playing with it. It's a weightlifting thing where I don't care if you can lift 100 pounds or 50 pounds. I'm going to give you 45, 55, 45, 55, 45, 55. If you can lift 100, I'm going to give you 110, 90, 110, 90. It's always going to seem like you've failed a quarter or a third of the time. On purpose. That's what I'm measuring. So don't feel bad that you think you missed some lights. It's going to make you miss lights on purpose. That's the test. I know I didn't so well. Look at your fields. Now, we have electronic records. Everything comes up on a screen. I turn the screen to the patient and say, there's your VFI graph. You're perfectly stable. And they get this big grin on their face. Couldn't be better. If you're printing them on paper, show them the paper printout. Patients don't know that they can take a break in the middle of the test. All you have to do, tell them, is to hold the button down and don't let up, and the test stops. When you're tired, press the button down. Tell the technician, I've got to stop. I need a rest. I have to stretch my neck.
The instrument's actually programmed to ignore that button press as well. It's not counted if they do that.
So remember the field checklist. Here's some fields, right and left. What do you think?
Let me go back to the patient interaction just for a moment.
Yeah.
Anders and I think that this is important enough that we devoted a whole chapter in the new edition of the primer we've just written, and which Harry has helped us teach. Read chapter 2. Give me your card, I'll send you a copy of the book.
If you just send the patient into the field test thing and then tell them at the end, some sentence about what happened, you're probably not getting as useful a test, and the interaction with the patient is going to be not as satisfactory for them. So it's really important, I think, to talk to them about the test and in these particular ways, and to give them a chance to vent a little bit about it, to tell you what they're worried about.
Small technical thing. Remember I told you I thought the GHT was not as specific as I'd like it to be? The EMGT criteria analysis progression is very specific. It has specificity in the 98 to 99% level. If it says you're progressive, you probably are, as long as your baseline fields were really representative of the patient's condition.
Now, what do you do? I mean, if somebody's progressive, what the heck do you do? You lower their target. You may, if you choose, I don't know, your particular practice, that may mean that if you saw somebody like that, you'd want to have another evaluation by another practitioner, by an ophthalmologist, whatever is appropriate, but you don't do nothing. That's the killer. You've got to do something. One thing to do is, if you think they're progressive and it suddenly got worse, bring them back within a month to do another field. I'll be betting you my Subaru that it's back up 90% of the time to right where it was, unless they just had a central retinal vein occlusion. So the field suddenly gets worse, full redilated eye exam. Nothing's changed, pressure's fine. It was a bad day for the field. Ask them how their life's going. Lady came in yesterday, both fields are terrible. Both fields don't get suddenly worse in glaucoma. How are things going? She'd lost 10 pounds. I said, you've lost some weight, haven't you? Breast cancer. Chemotherapy. Didn't tell the tech. Had to drag it out of her, having seen her fields, what was going on. Much more often than not, there's a divorce going on. There's a kid who's in jail. Does that affect the field test? You betcha. So find out what's going on with your patient, and you'll often find the answer to how the field changed. No change over 9 years in this person. The VFI is stable in its printout. Slope not significant. No progression detected. Happy camper. Everything's doing fine. Back off, do fewer fields. Somebody with upper hemialtitudinal defect in the right eye and the left eye, bada-bum, bada-bum, bum. This is catastrophic worsening. And again, this is age 46 to about 52. That's in under 7 years. There should have been something done back there. Patient was refusing surgery, actually. I know this patient. Okay, now we're going to look at structure, and then we'll put it together with the fields. So you do the same thing. You get a printout, either an electronic printout or a paper printout. Checklist is you look at the signal strength. This is the printout, of course, from the Cirrus. There is a printout from other companies that you'll have to learn. Up there it says 8 out of 10, 8 out of 10. 10 out of 10 is a perfect signal strength. That's the machine is saying, I'm not getting a high degree of variability. You lined everything up right. I don't have any big black spots where you let the patient blink in the middle of the test. Second thing is the nerve fiber, their color thickness. See that? You should see 2 flames coming out. And the reason this is important is a lot of people look like this picture. They have this C-shaped or backwards C-shaped arcing nerve fiber layer coming away from the disc. But tilted disc myopes, it's really cocked downward like this. And the machine will tell you that person's abnormal. And you look at those 2 reddish yellow flames up there and you see that they're cocked downward. Tilted disc, the machine got fooled. So look for that. The deviation plot I use a lot. This is this thing here. Any area that is statistically different from normal at either a mild or a significant level is either yellow or red. Now, the numbers we're going to get down here in nerve fiber layer thickness are all from only this circle right here. It's not, the statistics down here don't have anything to do with that or that. And we're going to see some examples here where you see a big wedge defect and the machine missed it in these statistics because it was only looking at one single point around that circle. I mean, if it gives you, it wouldn't be possible for the company to give you every single point's data, every single point's significance. And if it tried to do that, the variability would kill you. So they're not doing that. Let me, one more thing. You want to go back up here. And remember we talked about size of disc? Okay, so here's disc area right there. 1.5, 1.3. Is that a big disc or a small disc? Very small disc, right. So the cup to disc ratio of 0.5 and 0.5, that's suspect. Even though everything down here, now that you look, okay, now that I've looked at that, cup disc ratio vertically, 0.5, 0.46. Now I'm going to see whether at the ring of nerve fiber layer measurement, what's the thickness compared to the normative database that's in the machine. And green is good. This is quadrant by quadrant. This is clock hour by clock hour. You're more likely to see abnormality. Sometimes down here, if one hour was abnormal, you're more likely to see abnormality here if there's diffuse loss throughout a whole quadrant, even though each clock hour itself isn't bad. So you can see it in one or the other of those, and then put it back together with what you see there and there, and most importantly, put it back together with what you saw clinically in the patient. Now we're going to look for change over time with multiple OCTs. And here you see the tests, the first one, second one, third one, and you see a change map here. This is not whether it's abnormal in the original test. To see that, you've got to look back at the original test. This is whether it has changed compared to the baseline. There won't be anything red here unless the second and third one are different from the first one. So we say, well, where'd that wedge defect go? The first baseline test, there was a big red wedge defect. Well, it's not going to be there because this is looking for change. Down here, there are graphs of the thickness of the average nerve fiber layer, but what you'll pay most attention to is these boxes over here and whether the numbers of nerve fiber layer thickness changed enough that a flag appeared in color in either yellowish or reddish telling you, hey, there might have been a change, and we'll show you some examples. Okay. So this is a person in whom we see this OCT. Signal strength, 9 out of 10. 2 red flares, but notice that this red flare isn't as big as that one, and there's no red flare there, and this one looks kind of wimpy compared to there. This map, a little bit of yellow there, but look at this. Bada boom, bada boom. Glaucoma causes narrow, widening out wedges of damage, arcing in a C shape away from the disc. And there you see it. And the machine statistics suggested the upper quadrant there was abnormal. and found 1 clock hour that was bad. But I really believe this because I see this wedge-shaped defect. As a matter of fact, the patient actually has an inferior defect, but it missed it because it wasn't abnormal enough at the point of the ring of measurement statistically. So I know this person should have an inferior field defect, maybe an upper field defect, but structure precedes function. And so what have we got? An inferior field defect. It's not the most typical nasal inferior field defect, but it is real, and this is reproducible in this patient. So now what have I got? I've got a definitely statistically abnormal SD-OCT that's reliable and a field test that matches it in the appropriate hemifield. This is conclusive glaucoma. This is a patient who must be treated. Here is some follow-up on a patient. Field, field, field. And look at that. The VFI appears to be going uphill.
You cured him.
I'm putting back nerve fibers, right? No. Patient's learning how to do the test.
Slow learner.
Yeah. Here's one that has big open circles in it. What are the other flags? 11% false positives, abnormally high sensitivity, above 0 mean deviation, and a worse pattern deviation than total deviation. Happy clicker. 14% false positives. Over here, it doesn't say abnormally high sensitivity. It doesn't say plus mean deviation. Because when the patient already has real field defect, the only way you're going to pick this up is seeing false positive errors, not these guys over here. And what's the problem with the happy clicker is they can have a very normal looking field in some eyes when they're hiding their field defect by over-responding in the area where they really can't see. Yes, sir?
Can you go back one slide to the person who's getting better? Because the baseline is based on 2 fields, can you reset which 2 fields the baseline?
Yeah, you can. Absolutely. I have an example of that coming up. This, of course, you don't have to reset anything because you can see the whole picture all at once. Here, if you're only looking at the progression, no progression detected or something, let's say you did surgery. Let's say the patient had an operation. And that was done in 2012. Now you're wanting to see, did they get worse? From then, you can reset the baseline to be the fields that you did in 2013 and 14.
I would go
But you're kissing
further.
off all the rest of it. I like looking at it all. Do you?
I would go further. I would not let the computer set my baselines. It'll do it. We will do that for you, but I think you ought to critically review that at least once for each patient when you start using it. It'll remember which ones you choose.
Okay, here's another OCT. Pretty good quality, 8 out of 10. Flame there, no flame there. Truncated flames both places. Wedge-shaped defect, broad wedge. What's that? Why is, oh, what's that black stuff? The machine didn't get any data there. Might have blinked, might have moved. So ignore that, ignore this, but don't ignore that. Because this person, you can actually see the wedge-shaped defect as a dark blue right there. Here, statistically, that inferior quadrant crossing the ring there is abnormal, and it's 2 hours of the clock, tilted slightly to the temporal side. Ringing the bell. This is classic hourglass atrophy. Upper quadrant, lower quadrant. Something we showed histologically happens. Oh, look at that. How come the nerve fiber there was abnormal above and below, but only an upper field defect? Nothing going on down there, hardly at all. But the nerve fiber there was abnormal.
Around 5 minutes left.
Okay. Structure changes before function on average in most patients. Here's a patient who is getting worse, and yet slope is not significant because there's so much variability in those early fields that the statistical linear regression analysis can't call it. But you can see it. You know it's going on. Don't necessarily always believe the statistics when you see what you see. Let's move on. I'm going to move through these just for a moment. Here's somebody getting worse over time. Significant slope, 2.5 decibels, catastrophic worsening. Here's the follow-up of someone, and you're looking here for did something change in the average statistics for average nerve fiber thickness and the inferior and superior quadrants. This is somebody with a really bad field loss, and here's what it looks like when the nerve fiber loss over time is getting worse. It's either likely worse or definitely worse. And when you see that kind of color in the person who's had 3 or more OCTs, that's extremely helpful to point out to you. Go back and look at the tests.
And that can show up in patients who are still in the green relative to the normative data.
The question about baseline. Guy's getting worse, then has a tube shunt and levels out. Same story. Getting worse catastrophically, trabeculectomy, levels out. Thank God glaucoma therapy works. So here's our mention of the catastrophic patient. This is the paper you should read by Balshahan, BJO 2011. I think it's one of the most important papers written in the ophthalmic literature in the last 25 years. Talking about how many fields do you have to do before you can detect change. And if you're not doing a lot of fields early on, 3, 4, 5, 6 fields in the first 2 years, yeah, I know that's painful. Do it anyway. You will miss patients. There you go. I've already talked about SLT and ALT. We'll skip that. Trabeculectomy works, but it has complications. We've had to redo surgery for a bleb-related issue in 9% of patients in the last 10 years. So trabeculectomy has some complications. We've dramatically decreased the infection rate by moving to fornix-based flaps instead of limbus-based flaps. Unfortunately, the fornix-based flap gives a few more eyes with symptomatic hypotony, and we have to operate to bring the pressure back up. It's too good. Symptomatic hypotony. MIGS surgery, these minimally invasive, somebody asked me beforehand, we're investigating several of these operations. Right now, their success rate of any of them is nowhere near as good as trabeculectomy. They're worth studying. None is really ready for prime time. We are doing not quite as many tube shunt surgeries as trabeculectomies, and I still don't use it as the primary operation. It has been oversold as not having all the complications of trabeculectomy. It has tons of complications that are unique to putting a tube on the eye. Diplopia and tube erosion are 2 of those things, and they're being underrated based on the really fine work that was done in the tube versus trabeculectomy TVT study by some superior tube surgeons who do hundreds of them a year. But on average, tubes have a lot of problems. Now finally, we are going to be in our lifetime treating people for glaucoma to protect their ganglion cells. And one of the drugs that does that is ciliary-derived neurotrophic factor. We've gene-expressed CNTF in rats and blocked glaucoma damage about 70%. There is a capsule you can sew inside the eye. It's now being tested in human glaucoma patients with cells inside it that are engineered to produce CNTF chronically. The immune system cannot recognize that the cells are in there because they're in a little mesh, so this doesn't get rejected. It does require surgery to put something into the pars plana, but it slowly releases CNTF at a rate that is clinically significant, and we're going to see very soon whether this assists the glaucoma patient in further protecting ganglion cells on top of lowering their eye pressure. We are presently testing a group of drugs that do the same thing as CNTF, protect ganglion cells from dying, which are inhibitors of a molecule called DL kinase. It's a mainline way that ganglion cells die in glaucoma, and when you inhibit it, they live. We're putting it in nanoparticles, which will be injected subconjunctivally and slowly released over periods of 6 months to a year. This will replace not only add to glaucoma therapy, it's going to be probably how some of the age-related macular degeneration therapies are done instead of intraocular. But right now, you can't get the AMD treatments into the eye through the sclera. What we're working with are things that actually penetrate the sclera, so you could put them in the office subconjunctivally and have them release for 6 months. This is what the company that I have an interest in, Graybug, is presently doing. So you can, I'm telling you my daughter is pretty, but the company has real merit.